had been leading a movement to leverage all of the potential that nursing has to offer in advancing healthcare transformation. In 2016, AACN published a report called Advancing Healthcare Transformation, A New Era for Academic Nursing. Tom is co-author of this report. So how many of you have seen this report? Okay, good. And I hope you've stopped by the AACN table and picked up your copy of the report. We have many of them for you. Tom's presentation is guaranteed to give you many ideas and strategies to take back to your organizations. I just want to tell you a little bit about Tom's professional experience. For 30 years, Tom Enders has been working with leading healthcare organizations to improve the management and delivery of healthcare. He is one of the nation's leading strategy and operation and organization development consultants to academic medicine centers and medical schools, health systems, children's hospitals, and associations. Clients turn to Tom to lead complex, multi-stakeholder strategic planning initiatives for his expertise in the formation of new delivery system models, such as accountable care organizations and clinically integrated networks, and for his depth of experience in academic medicine, extending to research and educational missions. Tom also counsels provider organizations on Medicaid policy and provider delivery transformation, payment and reimbursement reform, mergers and acquisitions, and information technology strategy. Please join me in welcoming Tom Enders for this next session.
Thank you, Kathy. And I urge those of you that are here, if you want to move up a little bit so we can have a bit more dialogue as we go forward, that'd be great. So I welcome that. Okay, so it's a real pleasure for me always to join Kathy and the AACN, and especially to be here at QSEN in 2017, to talk about this theme, creating authentic practice partnerships. And this title itself has so much hidden code within it. An authentic practice partnership is really the essence of what I will discuss and how to achieve that, as well as where quality and safety can thrive. And certainly the QSEN competencies, the QSEN framework, and the whole work around QSEN establishes both a framework as well as a high benchmark for achieving quality and safety, which is so critical. And lastly, a new era for academic nursing and building on the work that we have done with the AACN and member institutions throughout the country to really think about a new era for academic nursing, which is a topic that near and dear to my heart. Okay, here we go, to advance. So I wanted to cover three things today. One, just to establish a bit of context for what do I mean by authentic practice partnerships. Second, to summarize the new era findings, and third, discuss a path forward for institutions that pursue it. And I do think perspective matters in this, and there are at least several major dimensions of the perspective. So the first, I would say, is the landmark IOM report, which really laid out a series of requirements and a future direction for nursing, focusing on workforce needs all the way through to really laying the foundation for interprofessional models, care management as part of practice, focusing on the care transitions and really care continuum management, and also on the primary care shortage and how to address it, and the need for research in quality and safety. So all of these are sort of laid out very well in the IOM report and have been a basis for ongoing implementation and development. Now, I would pair that with work that's been underway with academic medical centers, and as you know, academic medical centers are in the midst of a really major transition and evolution to become academic health systems. And academic medical centers in their Their legacy as organizations has been campus-based, largely medical school with a flagship hospital with affiliated professional schools. And that is changing significantly. They've become distributed, multidimensional organizations, and they're grappling with both identity as well as how to achieve that. And some of the issues that they're grappling with are, firstly, how to develop a broader clinical network that is distributed, creates more access, how to emphasize and establish a primary care base. And we all know fully well that we do not have enough primary care physicians to meet the demand for primary care in these distributed models of care. How to align governance and organization and management systems within the university, across professional schools, within the academic center itself. And this is a pivotal issue of that I will touch on, is how to achieve and align goals across what are organizational divisions within our academic health centers. An emphasis on the cost structure and developing cost structures that really not only reduce unit cost, but focus on total cost and utilization of services, and also how to bridge to research, practice, and education, which have long been the emphasis of academic health systems and academic centers, that they have a tripart mission: research, education, and clinical service delivery. Yet how often are these missions truly integrated? And in my experience, often they have not been. They've been siloed. Research will be conducted but not implemented in that setting. Education will be conducted in silos, and as you know from your own work, interprofessional education is often rhetorically supported but practically underwhelmed. So these are really important issues organizationally of how to achieve the promise inherent in these wonderful institutions. Now, as those of you who know me know, I feel that there's just unlimited potential in terms of the role of nursing in American medicine. I just think it's just a tremendous untapped reservoir, not only of talent but of potential. And this really came across increasingly clearly during the work to prepare the New Era report. So why is that? Where is this potential? Where does it lie? So, and I linked together three things, starting on the right of this particular chart. Firstly, there are societal imperatives that are just truly very powerful for changing how our healthcare system works, starting with a total cost of care reduction and really a reallocation of resources towards where they can be best delivered, a long-term trend towards delivery of services around the patient and truly a personalized model of care extending to the consumer, a very significant need and a commitment to improving access and coverage, the development of patient-centric care models and family-centric care models, the focus on quality and outcomes improvement, patient engagement and family engagement, and consumerism model of healthcare and care in the community, and addressing social determinants and fundamental causes and root causes of healthcare problems. These are huge social imperatives that create a primary case for significant change in our healthcare model. Now, on the left-hand side, we have some significant imperatives relative to academic health center development, which I noted previously, which are driving these organizations to change. And then we have also in the middle the imperatives of our nursing colleges and of academic nursing, starting with the imperative to address shortages in the nursing workforce, but also changes and the dynamic requirements needed for an enhanced nursing workforce with additional competency, capability, typified by QSEN certainly, but also in terms of the nursing leadership workforce and doctorally prepared nurses. Secondly, the expansion of translational research programs. I think most institutions have pay lip service to creating more impact through their research programs, but far fewer are actually doing that. A strong emphasis on really understanding how to drive research findings into practice and how to do that effectively. It's a very important imperative. Thirdly, the development of new care delivery models that both can improve quality, improve safety, and also improve the cost profile is very significant, and nursing leadership plays a critical role in the development of these models. Interprofessional education and clinical practice, and an enhanced role in clinical service management. So these imperatives come together, and then I reflect on, so how is it that the evolution of academic nursing can meet these needs? And I will tell you personally, as I work around the country, I'm really a practitioner. That's my job. I work with institutions day in and day out on many of these issues. And what I find is that in many of the kind of core topics, and this will be a theme I return to again and again, population health development, community engagement, addressing social determinants, developing new care models, where can we turn to get answers and action? And very often the answer needs to be, we need to involve our nursing leadership and our nursing workforce in developing those answers. And in some cases that's true, that is being occurred, but I find it to be far less than is possible, and thence my perspective that there's unlimited potential for liberating this capability. Now, in terms of the QSEN competencies, these QSEN competencies are powerful, and I appreciate that this conference in 2017 is focused on their further development. I'm going to touch on several of these as we go forward. My sort of premise is the framework is really good. There's a lot of initiatives that are underway in each of the components of the QSEN competency framework, but what are the sort of challenges that limit or inhibit the full flowering of the deployment of QSEN competencies? So one of the issues that we did in developing the New Era report was interview leaders throughout the country. And I'm going to share with you some of the findings from those interviews, and all of which point to a highly constrained environment for untapping the potential that I described previously for nursing. So the first is a kind of primary theme, that the integration of academic nursing into solution development needs to occur at multiple levels. And often we focus on one level or another, but not on the entire ecosystem in which nursing exists. So these are levels that are amongst professional schools, within a university setting, between a college and its healthcare affiliate, amongst academic and clinical practice. So multiple levels. So the ability to think broadly about this challenge so as to integrate at multiple levels is a key component. A second major theme is just the recognition of how limited there is in terms of the integration between academic and clinical practice. And when that integration starts to be realized through tangible projects, how powerful that can be. This is a theme that I counsel all of my clients to focus on, whether they're a hospital or a healthcare system, to integrate much more closely with their nursing college, or whether it's a nursing college or health sciences college, to integrate much more closely with their clinical affiliate, and to do that at the level of producing results. And nothing, and this is a primary criticism, I would say, from most academic centers to their affiliated nursing schools or health science colleges, that they're not sufficiently engaged in practice to be able to drive change, which they contrast with their School of Medicine colleagues, many of whom do have not only an academic role, but also a clinical leadership role. Third major issue is the role of nursing within our governance models in our institutions. And for a variety of reasons that are historical in nature, academic nursing leaders have a relatively limited, meaningful governance role in health system leadership and governance and organization. I think this is a real challenge because it means that a very critical perspective is lacking in the development of strategic solutions at the governance level. And so I don't really view the challenge here so much as representational in nature, but more in the sense of that's a voice that can contribute to meaningful solutions and change and bring the assets and talent of an affiliated nursing school to bear on what are some very big challenges. So for instance, as one example, I often ask my clients to see their enterprise workforce development plan, which I would expect to be not only for all of their clinical services, but perhaps also for their region. And you would be surprised at how many don't have one, or they have a piece. They have a strategy for addressing their inpatient needs, but not their ambulatory needs, or they have a strategy for developing their physician primary care services, but not their nursing shortages. I'll ask them, have you thought about nurse-led clinics for addressing some of your indigent care needs? And I would say maybe a quarter have and the rest haven't. So just the lack of what I see as real innovation in addressing strategic solutions that really leverage nursing. Another big topic I'm involved in is big data and the development of new models for analytics and informatics, which is absolutely fundamental to any kind of model for developing pop health. And you would be surprised and so many institutions are developing sort of big data or informatics programs, but very few of them have really seen the benefit of really driving that through nursing or having nursing as a key partner in that, which I think is essential. So these are kind of examples, if you will, that I think are manifestations of what happens when there's insufficient participation by nursing leadership in governance, which is where strategy is set. So that's a theme I feel strongly about. A fourth is, which I mentioned, is the whole process of strategic planning in our major healthcare institutions, which is often siloed. I had a client recently in which it's a large multi-hospital system. They had developed a strategic plan, and simultaneously their affiliated nursing school had developed a strategic plan, and they had not consulted with each other on their respective strategic plans. Now, we have a few exemplars that have done that have integrated their strategic planning efforts with very positive results, but that's the exception rather than the rule. So I think being thoughtful about how one does strategic planning and to do it in a manner that's integrated. Another major challenge is the economic basis upon which nursing schools and colleges are established, and they're predominantly tuition-based. That's the basic economic model for nursing schools. They have tuition is 85% or so of the economic base, and then the rest is a mix of grants and foundation support, but very little clinical support, and this makes it very difficult for nursing schools and colleges to invest in new programs. Very difficult. It's a real challenge. And so I think that the development of nursing practice is difficult on its own, but should be undertaken in collaboration with affiliates to really develop nursing practice, particularly as nursing practice becomes increasingly professionalized on an ambulatory basis. And I do believe our future will have very large and significant nursing practice models that develop and expand, mainly because that's necessary to have increased access and to support a pop health model. So I view it as inexorable, and I feel it's lagging significantly. I will also say that on the sixth theme, that the coordination of the overall nursing enterprise, that is the overall nursing enterprise, meaning not only clinical nursing but also and practice nursing, but also academic nursing, is often approached with a narrow view by leaders across the entities, without this kind of thinking about where are we really going institutionally and how do we really deploy the strengths that we have in our nursing enterprise. A seventh major theme is that nursing clinical and administrative leadership development skills must be developed. Everything I've described so far requires leadership and leadership skills, and often that is an underdeveloped part of the professional development of nursing clinical and administrative leadership. And there are increasingly programs now to support leadership development, but really thinking about leadership development as a competency in and of its own right, in addition to the many other skills that are necessary to be a leader, is necessary. And so I encourage institutions to invest in those leadership development programs, to have mentorship development programs, to have tracks in which they identify early on potential leaders and give them leadership opportunities so they can grow and strengthen in their careers. Now, the eighth theme is a particular subject of mine. So I am involved in many research programs across the country, primarily biomedical research efforts. I work with many schools of medicine on their research programs and research institutes. And you probably know this, but the major funder for research in our country is the NIH. The major public funder is the NIH. And 1% of the NIH's budget goes into nursing research. So to me, that says it all right there. It's just a hugely underinvested dimension of our research enterprise, particularly when we give a lot of lip service to wanting to engage patients and to have a much deeper understanding of the issues that are required to manage chronic disease and to understand and address social determinants and to deal with community engagement issues and also to translate innovation into practice. And these are all topics, of course, that nurses are very good at and really have a great deal of competency and capability around. So I feel that there's just a very significant opportunity to expand and develop School of Nursing research programs, which have been starved of resources and are largely underdeveloped relative to almost every other kind of research that goes on in our biomedical research sector. So I feel this is a significant issue. And there are a number of root causes for this, of which financing through the NIH and other institutes is a dimension. But also I would say that there is a gap in terms of the professionalized research development, the sort of PhD-focused nursing research leadership required. So I think this is an area of development as well. Now, the business case for academic nursing for these investments and for these changes does need to be clearly stated, and at the end of this presentation, I'll give you my elevator pitch for what I think that business case is. And lastly, the nursing programs are under-resourced, as I've mentioned. So that's kind of a summary, if you will, a diagnosis of why it's so difficult to get leverage on this. And the result of that has been this kind of significant organizational challenge typified on this diagram. On the left, today's view of schools of nursing and the clinical practice is siloed. It's a siloed view, and with limited cross-entity governance participation, limited shared leadership position and roles between faculty and practice and faculty, without a true nursing clinical faculty comparable to what we see in schools of medicine, that is, that are really deeply engaged in the conduct of the clinical services, a siloed mission focus with a sort of division of labor without an integration of resources, and with entity-specific strategic planning rather than integrated strategic planning, and with limited financial integration with under-resourced colleges. So I view this as a real challenge that we have to change. I feel that strongly. So I feel that developing an enterprise view with the requirements that I described previously, including a participatory governance model, increased joint appointments that can lead academic and clinical programs. I'm a big believer in the role of joint appointments, either for practice leaders to have adjunct faculty appointments in their affiliated college, or for the faculty to have appointments, clinical and administrative appointments within their affiliated health system, to really look at that bilaterally. Growing the clinical faculty in the School of Nursing that can maintain a practice within the health system. One of the striking findings we found in our New Era interviews were that many of the faculty were needing to maintain their competencies outside of their affiliated health system, which I find just really outstanding, needs to be changed, and really having a strong commitment for the faculty within the health system, undertaking joint strategic planning, having a financial support model that can facilitate School of Nursing investment in key programs, whatever those might be, research programs, but also innovation programs to develop new models, and growth and integration of the research programs into the clinical practice. Now, and we looked for exemplars throughout this New Era report, and many of them are noted in this report, and we did find some. We didn't find any that sort of had it all. You know, that was a rare finding, even though we looked hard. But we found a few institutions, I would say maybe 10 to 15, you know, so it's a small number, that really have begun to to really deploy this enterprise model. And they are very encouraging of their colleagues at institutions as to the beneficial results that they've realized from that. So a few other constraints, and then I'm going to go on to what I see as the opportunities, but just to round out the picture. So of course, I mentioned the first one, federal funding for research in schools of nursing is insufficient to meet the imperatives of healthcare reform at a structural level. Secondly, the scope of practice. Laws still vary widely across states and are largely a major barrier to enhancing the clinical practice of nursing faculty and the nursing profession at large. So this is a major, major issue. The future of workforce education and of clinical practice is interprofessional and has been nicely laid out by IPEC, but the practice hasn't caught up with the theory and rhetoric, and many institutions have good theory and good rhetoric around this, but have limited implementation of initiatives. They have some, but certainly not to the degree that IPEC has called for. A fourth major constraint, I would say, is the primary care shortage is real. This is an opportunity as well. And nursing is an absolutely essential component of the short and longer term solution for addressing primary care needs. However, the rarely do workforce strategies recognize this and are dealing with it in a foursquare manner. And lastly, the integration of research programs between schools of nursing and schools of medicine and other health science schools, including public health, is missing, and a significant opportunity is lost. And I view this on all sides, and I encourage nursing deans and nursing leaders to really do everything they can to break down those silos themselves rather than to perpetuate them, and to encourage them. So kind of silo busting is everybody's job. Now, just a few notes on emerging exemplars and some institutions that we have noted have undertaken some significant changes. So first, I would say participatory governance. And an example are both ELMS and UAB. We have a representative from UAB here today, Terry Poe, and there may be others of you in the room. The first, I would say, is that the School of Nursing has a governance role at the health system level, typically as a director, as well as the nursing clinical practice level that facilitates inclusion of academic nursing perspectives. So that's important. Elms College also has such a model with Bay State Health. Second, integrated leadership. And an excellent example here is the University of Rochester that has created a fully integrated leadership model amongst its professional schools and health system. And through that integrated model, they undertake integrated financial planning, integrated strategic planning, integrated labor and workforce planning. And this has been very valuable to identify initiatives that are cross-institutional. Third, I would say around integrated program development and management. And here I would point to both Penn as well as UCSF, as well as Rochester as exemplars, where there is a robust clinical faculty that practice and teach in the health system. I think that's a very important dimension. But also I would say that research and educational programs are active within the health system with a strong degree of bilateral and innovative activity that can lead to third-party program funding, grant funding, and importantly, new innovations. Now, a fourth example I would use is Michigan and Columbia, where these institutions have established financial models that support nursing enterprise development. And these examples include either School of Nursing funding models, School of Nursing clinical faculty practice plans, whether they're independent or integrated with the faculty School of Medicine practice plans, as well as resource investments in specific faculty that will have a research interest. So that's an important component. In terms of research, I think having a real sense that the future of nursing research does not need to be led or driven only by RNs. I think this is a really important component. And this has really held back schools of nursing because there's not a track for a PhD researcher, though we are seeing some of that. The numbers are very small of nursing colleges recruiting PhD researchers to be in their research faculty, which is a common model for research development, particularly in data science. And I think this is an important issue that is being recognized and being developed. And I do expect over the course of the next decade for some of our nursing schools and colleges to become leaders in informatics, not just in nursing informatics, just in informatics science broadly, but to do so they will have to have a track in which they're able to recruit and develop PhD scientists. So that's an important component. I would also say that the focus on standard of care, evidence-based practice, is an absolutely fundamental objective, particularly when we get into distributed sites and services that include telehealth and other models that are distributed. We're no longer able to control quality at a site level unless we have, and in a distributed model, unless we have standards of care. And I view this will require a significant investment in informatics, IT, and the analytics to support it. And then lastly, I would say, and I would point to Florida and NYU as two institutions to look to in this regard. Lastly, in terms of integrated workforce development, a key topic to really focus on understanding and developing. And I really think that the model here is to have a regional development plan to sort of pair with a community health needs assessment, a true regional understanding of what are the workforce requirements for the region and to participate in developing solutions for that region. So to summarize where I see these unlimited potential opportunities. So really, I would say broadly in three areas. I think certainly the most pivotal and fundamental is around patient care leadership, and I think that's important. The focus around continuity of care, continuum of care management, population health management, community engagement, all of these, I believe, are absolutely essential for system-based care. And we're clearly in a very significant generational transition from hospital-based care toward systems of care. And I think that the nursing leadership around this fundamental transition is essential and will become increasingly important as we go forward. And you can see a number of the kinds of initiatives there where leadership can be actualized. The second major area is around workforce development, and certainly the growth in advanced practice curricula has been a very essential component. The preparation of doctorally prepared nurses, which the IOM called for, has been progressing, still significant opportunity. The interprofessional education programs in which we truly have integrated teams, team-based care, a topic that we all aspire to, but is still very underdeveloped, not only between nursing and physicians, but also with pharmacists and dentists and other health professionals and technicians of all kinds, having a true team-based model of care, and then training curricula that prepare clinicians for the future in which healthcare is delivered in many distributed settings. So this is a very, very fundamental dimension of leadership. And clearly, I think one of the gating factors here is that the faculty of nursing schools and colleges needs to be invigorated with the next generation of faculty that really are very attuned to all of the new models and who have the drive to innovate using technology and other tools that are necessary. So the kind of that, and that's a big question that I have for a lot of you is, where is that next generation coming from? We have a real gap coming in terms of the nursing faculty. So very important to think through new strategies for developing a pipeline for faculty, for encouraging younger individuals to enter the faculty track, and for leveraging adjunct faculty as well. So very important topic. And the third is around research leadership, as I described, around the science of quality and patient safety, optimal care delivery models, what really works. And there's so much that's unknown, as I think of one example, which is just, I think, critical. So just to give you something that's on my mind. So as many of you know, we've, through better diagnostic tools, the prevalence of early stage breast cancer has become, we have a huge increase in women that are diagnosed with early stage breast cancer, a massive increase. And And this typically is non-invasive, but is important. So we have a large cadre, a large cohort of women that will be living with breast cancer for the foreseeable future. Yet we have very, very little information about the treatment modalities for those patients, what really works, what are the long-term effects of different kinds of therapies, and we have very little long-term tracking. It's just an excellent example. So there's certainly some meta-studies that have been done, but the science around it is relatively thin. So that's just one of many examples of thinking about what are optimal care delivery models, particularly for long-term management. The symptom management, chronic condition management, and the science of leadership, all of these are areas where I would expect far more nursing leadership in the future, and I feel creates a significant opportunity. So these are three important areas that I ask leaders of universities, of academic centers, policymakers, and deans around the country to focus on how to really leverage academic nursing, and I think they're all extremely powerful. Now, this perspective of challenges, constraints, and opportunities led us to develop our New Era report recommendations, which I'm going to summarize for you, and they're captured in this auspicious-looking diagram here. There's 6 of these recommendations, and we urge institutions to implement them. And I'm going to walk through each one. I appreciate your patience with that, but I think they're all relevant and they all interrelate. And the first is really to embrace a new vision for academic nursing and to really call for a rejuvenation and a recommitment to a new kind of academic nursing that addresses all of these opportunities, that addresses the focus on patient care leadership, on workforce development leadership, and on research leadership. The second is to enhance the clinical practice of academic nursing and to forge a new commitment to the involvement of nursing faculty in clinical practice and to create bilateral program opportunities for real integration between academic and clinical practitioners. And so this is really around the focus of an authentic partnership. And without that bond, it's very difficult to see how one can have a truly authentic partnership at the institutional level, because this is really where the work gets done, is when you have faculty working with practitioners, trying new things together, developing new concepts, developing new programs, developing new courses, training students in novel settings, and really focusing on the QSEN competencies. So this is really where the rubber meets the road. So I think it's absolutely imperative that this be present. The third is to partner in preparing for the nurses for the future, primarily around going beyond rhetorical flourishing and arm waving in IPEC to really doing it, to really going the distance, to really making the investments necessary to really accomplish everything that IPEC promises. Fourth is partnering the implementation of accountable care. And in my view, so accountable care is both a concept as well as has some technical dimensions, but fundamentally is based on a concept of panels of patients organized together into a population and structured through risk-bearing contracts. The competencies associated with doing this are significant. This is where the transition from a hospital to a health system happens, is through the implementation of accountable care models. And remarkably, in the accountable care models that have existed, whether they be the Medicare State Savings Program, these have largely been physician-driven, and with reluctance, I would say, to be honest, because there's a strong bias remaining towards a fee-for-service model. And when I look for leadership around like true value-based delivery of care, I really want to look towards the nursing leadership, because I think they get it and are much more committed to this kind of work than many of the physician colleagues. So I think this is a really significant issue to work through, is partnering in the implementation of accountable care and leveraging the resources and talents of the nursing leadership. Fifth is investing in nursing research programs and better integrating research into clinical practice, as I've described, and I think informatics is a pivot, but not the only area for that. I think also new models of care and community engagement are critical components. And lastly, implementing an advocacy agenda to support a new era for academic nursing. advocacy, certainly at the federal level through AACN, in particular around really recognizing the need for investment in our colleges and in nursing research, amongst other things, advocacy at the state level in terms of scope of practice, advocacy at the institutional level in terms of the role and promise that nursing provides. So this is kind of a summary, and now I'm going to just walk through each of these a bit and give you a perspective. So what do we mean by a new vision? So a new vision is in which academic nursing is a full partner in healthcare delivery, education, and research, integrated and funded across all professions and missions in the academic health system. So a true interprofessional organizational vision. And you can see there some of the dimensions, the manifestations in which you would know if that vision were being embraced. Nursing participation, health system governance. I've been encouraged by what I've seen as sort of early flowers since this report was published, I guess 2 years ago now, in which I've seen many more nursing leaders become parts of governing boards of their affiliated health systems. I think that's a very good trend. Expanded nursing leadership in clinical practice and care delivery, that's another manifestation. The growth and evolution of academic nursing research programs in partnership with the medical school, with the health system and other professional schools, in which grants are being co-led, are being developed and prepared and thought about together, in which innovative, multidisciplinary, interprofessional programs are being established. So one example of these kinds of programs is around social determinants, which is truly a very fundamental and complex issue to understand, where there has not been nearly enough research done as to understand how to affect interventions at the community level that can truly, and of course if a health system has decided to embrace population health, they must, of course, involve, and we have many states around the country that have embraced Medicaid transformation, and one of the ways they do that is by implementing a pop health model. Our institutions are truly not ready to undertake their part of the responsibility in undertaking a Medicaid accountable care organization. They just don't have the competency or the resources to actually fully achieve the promise that creates. But I think that the development of this kind of partnership does begin to create that opportunity. Collaborative workforce plans and training, integration of academic nursing into broader population health initiatives, another very key component, and a system-wide commitment to leadership development is another dimension. So embracing a new vision, I think this needs to start at every level in the institution, but as much as anything, this is a top-down requirement, I would say, that starts at the enterprise level, at the level of the deans, at the level of the president of the university, if that's the setting, or the CEOs, as well as the dean of the college. So a true leadership perspective is important. A second major component is to enhance the clinical practice. And probably the first and most important component is to establish clinical leadership positions for faculty which link academic nursing faculty to clinical practice leadership and vice versa. Now this begins to resemble to some degree the relationship that School of Medicine faculty have had with their affiliated health systems. And this is not to say that every faculty member in a college would have this, but certainly some should, and creates a dynamic of much more collaboration around real issues that are impacting the delivery of services in that setting. Now, and I think it's a danger in every academic setting to be in an ivory tower. That's a kind of a common feature. And there's good things about being an ivory tower, but there's also, things that are less good, which is one is more removed. So I think that having the ability, implementing this first dimension here, really breaks down some of the barriers that have existed towards impacting healthcare delivery at the level of patients and families. Second, facilitating joint clinical program development between nursing faculty and clinical practice leaders. with a particular emphasis on ambulatory care and population health. So most of the growth in our health systems is, of course, occurring in the ambulatory setting. That is where the large growth is. And we are at the very beginning of a sort of massive change in how healthcare is practiced and delivered, which will be ambulatory in nature. And we're not really, this is early stage, it's not really developed. Of course, we've had a big growth in hospital-based ambulatory services as a first step in that process, but I tell you, it's just a very early stage. We're now getting to the next stage in which we have distributed ambulatory sites that are proliferating, retail sites, micro-hospitals, urgent sites. Telehealth is in its very early stages, but now there's millions and millions of dollars going into startups to provide consumer-based telehealth solutions. We'll have a future in which we'll be very distributed in the use of telehealth models. So I see a very significant need for health systems and hospitals to develop innovative models for ambulatory care and for managing patients in a very different setting. And I think this is an area of tremendous opportunity and innovation for our colleges to step up to the plate and develop new programs and innovative models to support this. The third point of growing the academic nursing clinical practice, I think, is partly attendant to that. I feel that there's a tremendous opportunity to expand the role of nursing broadly on an ambulatory basis as a component of the professional services capacity of a major health system. I think this is a huge opportunity. Of course, you're training many of the APRNs and other health professionals that go into these practices, but they're not organized or deployed in a manner that's closely affiliated with the college typically. Expanding clinical integration with joint appointments and practice integration, I've mentioned, I think that's an important goal. Promoting and expanding nurse-managed health clinics, I think, is an extremely important dimension to meeting the access challenges and the care management challenges. I think the patient-centered medical home concept has been proven to really have excellent potential, but the number of nurse-managed health clinics remains very small relative to the potential for these clinics. And I think this is a really extremely necessary dimension to certainly manage the transformation of Medicaid, which is probably the single biggest issue that's occurring in health reform today, but also more broadly than that. And then I think expanding the participation of academic nursing in next generation payment arrangements, whether they be bundled payments or at-risk models for pop health. So these are all dimensions I feel is important. And I think this is, on the one hand, I think the faculty in our schools of nursing need to become more proactive in stimulating these kinds of interventions and opportunities. And I think the colleagues in the health systems need to become more proactive in reaching out to their nursing colleagues in their affiliated school to participate. So there's a real communication requirement to undertake these activities. The third thing I will mention the third recommendation relates to partnering to prepare nurses for the future. New models of care delivery certainly is important, and we are at an early stage of the development of many of these new models that incorporate distributed models that link inpatient and outpatient services, that address chronic care management, that address transitions of care. These are all areas that I feel that nursing needs to lead. Team-based interprofessional training, there's, I think, an excellent framework for doing this. What's required is action to implement it at the level of curricula, at the level of facilities, at the level of team-based integration, and lastly, an emphasis on health services and population health research. So these are very important dimensions to really focus on innovation. The fourth is in implementing accountable care, and this schema provides 4 levels that are how to think about accountable care. The first level is really focusing on primary care, patient-centered medical homes, with a resultant emphasis on reducing preventable ER visits and admissions, appropriate testing, and prevention and early diagnosis. I think this kind of foundational level is missing in many, many regions, many institutional settings. And I expect nursing to provide a significant participation in partnership with clinical colleagues to establish this foundational level. The second level is around major specialists, and the third level is around distribution and management of complex patients, including long-term care and home health. And the fourth is at the level of public health. And nursing leadership needs to play a role in each of these levels, but the important issue is that they link together. That's what accountable care is a system of care. That's the problem with our American healthcare system. It's not systemic. And this is something that, and I don't want to be it oversimplistic because I'm neither a doctor nor a nurse, but nurses are really good at systems. And this is what we need, right? So we need a systematic approach to managing healthcare. So I think the focus on accountable care and pop health is a very important dimension for our future colleges. The fifth is investing in nursing research. The potential yield is great from the investment here. And I've mentioned the need for new types of PhD researchers to be incorporated into the school to lead research programs focused on quality and safety, population health, care model redesign, biostatistics, and other newly emerging areas. A very valuable type of research program. And to really have a focus on translational and on impact and on the integration of those innovations into clinical practice. So a very significant component. And this schema takes T1 through 4, which is a common way of describing research from early basic research, which is done in a basic science laboratory, a transition into a human model of care, all the way through to T3 and 4, transition to practice and transition to population health. This is a really useful model for thinking about where can nursing research programs fit. And you can see there, I've noted them as some examples of model School of Nursing research that I believe create opportunities. So an example, for instance, in T1 research, which is really preclinical and physiologically based research, would be epigenetics of pain, so which is a really huge topic, poorly understood and poorly managed in many cases, but a hugely important topic. So that's an example of a more basic science-based research. In a T2 type of model, which is typically around phase 2 and 3 clinical trials, an example would be, given there, hypertension, epigenetics, and African American families. And you kind of get the theme here. There's a kind of a genetic management theme, which I think schools of nursing could be very significant participants in. Third example around transition to practice. These are typically phase 4 trials, and importantly, health services research. And a model School of Nursing research program there would be around nursing workforce development and systems of care. What makes systems of care effective and efficient in delivering services. Fourth is in terms of population health, and an example there would be school-based obesity programs and prevention and their ability to address epidemics. I think another example that's very much of the moment now is opioid epidemic management, which is a huge issue at the individual level and at the regional level, overwhelming a number of our health systems in rural areas around the country. This is another example to have a really good use of School of Nursing research, which could focus on community engagement models, linking community resources with health system resources to manage opioid problems. So a very, very broad agenda, but I wanted to point out just how many places there are here for our schools of nursing to provide leadership in a nursing agenda. The sixth major point is to be fierce on advocacy. I've mentioned this as just an absolute requirement. I think AACN does a great job and needs the support of all of the members to continue to do that, and as well as at each institutional level to be fierce on advocacy in its own setting. So I wanted to conclude with giving you what I view as an elevator pitch for why I think investing and developing and committing to a new era for academic nursing is so valuable. This is an elevator pitch for any who will listen, and I provide this frequently with the people I encounter. I urge you all to do the same. So perhaps first I would say is aligning the academic health system clinical and academic leadership creates new value. There's no question in my mind, and I know Terry's here. I'll ask her to comment if she chooses to on what she's doing at UAB with her colleagues to create new value. So, and I think this is always, and this is true in all of our professional careers, our focus is to create value. We need to create new value through this kind of partnership. Second is to build population health capabilities. That's really the challenge that we have in front of us. New care models, data analytics services, new clinical interventions, patient engagement techniques, continuum of care integration, the consumerism revolution, really figuring out how to manage in a population health framework. We want to do it, but our ability to do so is much less than our desire. I think this is an absolutely key area where an authentic practice partnership can yield results. Third is to develop a foundation of primary care resources and enhancing access to the health services and the health system. There's just no question that we have insufficient physician primary care to meet our access needs. It just isn't enough. It's just not there. And it isn't going to be in the foreseeable future. So developing a foundation of primary care resources, which really leverages the training that our schools of nursing is doing to develop a primary care model, and then to have those nurses work in a distributed ambulatory primary care setting, is a major and material contributor to solving this shortage. Fourth is innovating and integrating biomedical and health services research into the health system to improve care and deliver impact around the areas that I described, a major opportunity. And fifth is preparing the workforce for the future in an interprofessional, team-based model, which will be prepared to address the technological opportunities and challenges of our coming generation. Now, with that, I want to urge you, if those of you who haven't, to access the New Year report, circulate, distribute, talk it up, and, develop your own elevator pitch. With that, I'll ask Kathy to make a few final remarks, and then perhaps Terry can comment as well on what UAB is doing, and any of you who have questions or want to comment on what you're doing in your own institutions. And I greatly appreciate your attendance on the last day of QSEN. I know many of you are going home soon, and I do appreciate, because I think I'm very passionate about this subject. I believe in it deeply. I know all of you do, and I thank you.
Okay, are there any questions for Tom? If you want to come to the mic. We'd also be very much interested in just hearing. We really, Tom did a beautiful job with those 6 recommendations. And we'd love to hear what you're doing in your organization related to those, or any comments or any questions. I was really, really excited to see as I went around to the different concurrent sessions, and when I saw the posters, there is so much great work being done related to all of these 6 recommendations, and I'd like to commend all of you on your great work. So we have some time. It would be fun to share and inspire each other, and Tom inspired us.
I think Terry should inspire us. I think that mic's live, but if not, you can come up here.
Thank you for your comments. I feel like fate brought me to your presentation today. In 2 weeks, I'm going to assume a role as the Chief Nurse Executive for an academic health system and maintain a role as Dean of our small College of Nursing that's affiliated. And I appreciate the roadmap that you've given me to think about in the days ahead. One of the questions
where is that?
Dartmouth Hitchcock in northern New England.
Great, a great institution.
Thank you. One of the questions I'm mulling is back on your slides about integration, and you gave some wonderful examples of large academic health centers who have gone through some of this integration work, and I was very focused on the slide about financial integration. And I forget the 2 organizations. I think Rochester might have been one of them. And what I'm wondering is if you have any more detailed information on how they've managed to figure out that even in the clinical area, that nursing is a revenue generator such that they can actually share resources and development opportunities with their schools of nursing.
So So I will comment on that. I can comment on Rochester in particular, and then if you give me your contact information, we have a lot of additional work paper and other information that may be of use to you in that regard. So our academic health systems fall broadly into four kinds of categories: those that are public and highly integrated, those that are public but not integrated, those that are private and integrated or not integrated. So that's the theme. So in the case of institutions that have a governance integration like Rochester, it's highly facilitated because you have a university president and then you have a leadership cadre that have their respective budgets. And the issue is that in many cases those have developed as independent silos, but there's an opportunity, because they're all in an integrated university structure, to become more aligned. So that's the case at University of Texas would be another example, University of California is another example. So in those settings, I think it's far easier to develop the degree of financial integration because one does that through collaborative leadership and teamwork to focus on what are our priorities, and the Dean of Nursing will bring their priorities forward, the Dean of Medicine will bring their priorities forward, the CEO of the health system will bring their priorities forward, and so forth. And you have a real dialogue mutually about priorities and choose to make investments within an enterprise financial model. So that's kind of one answer. And I think that's itself, by the way, is relatively underdeveloped even in those major institutions. So, but many of them were at least talking together about priorities and resourcing, which is a start, and having more transparency around it, which is an important dimension. In other cases where you have an independent college that works through an affiliation agreement, we need a different set of tactics because we don't have the ability to focus on an annual overall budget with different components. We're focused more on an affiliation agreement structure. So there I think it's less developed, but I think a focus for financial integration can be programmatic in nature, in which there's a commitment to specific programs. And Terry may talk a little bit about, UAB happens to be one of the ones that's public and integrated, so they have some flexibility. But Terry can talk about one of those programs, which does include providing resources from the health system to the college specifically in support of an intervention. So a programmatic investment. And I'm very encouraging of these. I think these are, you have a scope of work, you have a contractual agreement or an affiliation structure agreement that's specifically focused on leveraging the assets in the School of Nursing to deliver a result in the affiliated health system. So with that, I think it's great what you're going to do. I look forward to hearing about it as it develops. Terry.
We have a brand new example. This is kind of the perfect time. We realized that one thing we were struggling with was our discharge process for our patients, and that was resulting in high readmissions. We started looking at the process, and since nurses are doers, so we want to find the first thing and fix it, and we were fixing it, but inappropriately. So we reached out to the School of Nursing, and we came together as a big group, and we looked at the entire discharge process, which was painful to us because it meant drawing it and looking at the steps and finding it, going through the whole process and not just fixing the first thing that was broken. But we divided our discharge process into 3 buckets. And the first bucket was this document that we give our patients on the way out the door was 17 pages of terrible. It was just terrible. I mean, there were some pages without words. There would be 3 or 4 words on one sentence. It was just not good. So we put that in the beautification bucket. And the second bucket was what we're telling them was not evidence-based. I mean, we were using information that could be customized, so every doc could customize their own stuff. And we had 3,000 choices of things that could go into this from an education standpoint. So it wasn't, from a literacy standpoint, it was too complicated. So that became the content bucket. And then thirdly was how do you administer the information? So, because I am not attention to detail, I want the first page to be really pretty and jump out the things that I needed to hear. But we had people who needed to see a video, and we had people who needed to have teach back done, and now we can record a discharge instruction on your iPhone and your family member can listen to it when they get home, or we can video it, but we weren't giving our patients options. So when we brought the school in, from an academic standpoint, they slowed us down, they helped us diagram it. We realized we had multiple issues, and now they're helping us through not only changing the information, the beautification project, but helping go in and train 3,400 nurses how to best assess the patient's learning needs and then choose the best option that we'll be presenting. So from a measurement standpoint, we know we'll be successful if our readmissions go down, and our HCAP scores in the discharge domain were terrible. So people were getting great care and they're picking us. I mean, 9 out of 10 are saying UAB is the place I want to be. But on the discharge category, we would be in the 2nd, 5th, 9th percentile when it came to other organizations. So overall, it's a great project. And to your finance point, really, we're building a new school of nursing. So really what we wanted to do is contribute. We wanted to be able to move some finances over to the school, but we wanted to have a project to work together and to do that based on a reward. So we're able to do that now because in 6 months, if our readmissions go down, then we can truly put a dollar value on what the project has meant to our organization, to our patients.
And so is in that agreement, Terry, is the School of Nursing, are they able to receive an incentive payment based on those results? It's a results-based model?
Exactly. It's results-based. It's a 6-month look back. And we have kind of multiple projects in line, and our system CEO, Dr. Will Fernandy, has wanted us to do this forever. And we've had a hard time finding that thing that we could improve. But this feels right, and they're very evidence-based savvy, and they bring in best practices, and they have relationships from all over the country and are able to say this is the way their places are doing it. So we're very encouraged. We have, and we're doing. Our first meeting was 40 people. That's probably the greatest challenge. But that gave us 3 buckets to do the work, and we fixated it on our pillars so that we have, using the pillars of the organization gets the attention of everybody from strategic planning to physicians, because everybody wants the pillars to be achieved. So we did pretty good work aligning everything with the pillars so we would keep attention from all interprofessional groups.
I think it's just a great example, and really goes to one of the fundamental tenets of creating authentic practice partnerships is creating value. And once you create value, as you create value, you can share that value. And that, I believe, is going to be one of the ways that our nursing colleges need to become more financed in the future, is to have a stream of that income. I don't see it occurring as an across the transom funds transfer, but I do feel that it could be programmatically based and based on real results.
Hi, I agree with the value and also about the systems approach. I teach clinical nurse leaders, and nurses are doers, and the clinical nurse leaders are also systems level change agents. But I was wondering, is there any money left in the Innovation Center for Medicare and Medicaid in terms of financing some of these projects?
So the question really is what's going to happen to those centers. And in the federal budget, they get largely swept away. So that's, if you're referring to the Federal Innovation Center, CMMI.
Yeah, I think it was $10 billion over 10 years was available for creating innovative models, and nursing didn't really get a lot of that money, but in terms of finance.
Very little. And one of the things I encourage is the kind of practice partnership in which even if the lead entity submitting for those grants is in the school or the health system, that the nursing team is brought into it, which has occurred in some cases, but if you look at all the CMMI grants, it's very few, far fewer than it should be in my view. So I think it's an opportunity. I think the challenge is, so the answer is there is money in CMMI, even though those grants are largely underway. However, the future of CMMI itself is unclear in the federal budget. So I would certainly look as well for opportunities at the state level relative to the Medicaid transformation, such as
I'm in
district
California,
funding.
and that's tough.
It's tough, except that California has a big DSRIP program.
A big what?
DSRIP program.
Yeah.
And so the new waiver is been implemented, and there'll be monies flowing through the new waiver to support innovative models that should be taken advantage of for what you're describing.
Do you think a partner with the federally qualified health centers might be a good one in terms of pilots, like in San Francisco, or?
I do. Yeah, as well as with the public hospitals. I think they're probably likely to be a better partner than an FQHC, though I think an FQHC can be a good partner. Just it depends on which one and how they're structured and whether you feel you could work with them effectively, whether they have the scale to support an effort. Yeah, the network would be good.
Good morning.
Good
My
morning.
name is Terry Chanel from Jacksonville University in Florida, and I thoroughly enjoyed your presentation. And I just was going to mention, we just wrapped up a 3-year grant to develop academic practice partnerships in Florida. And my research partner and I went around Florida and developed QSEN and invited academic and clinical agencies to come. They received a full day of workshop, continuing ed, but there's no such thing as a free lunch. At the end of the 3 years, we expected them to come back and present on their partnership. We had about 138 attendees from across Florida, but the lessons learned, we only had about 6 teams come back in year 3 to present. So there was a couple of lessons learned. It's maybe more challenging than what faculty think to form these partnerships. Competing demands, different agendas on either end, but it was very successful. And next week, we've actually now become a regional QSEN center, and we are doing an interprofessional patient safety forum, and I'm happy that we've got about 200 registrants interprofessional. So it's all coming together. So it did have a success going forward.
That's just outstanding. Congratulations for that. And I appreciate what you said about, the difference between the sort of initial participation and going the distance. That's often the challenge. The
Right.
opportunity is so palpable.
Right, very energetic, but to get that partnership going and what you want out of it. But I did want to mention, if anybody's interested in seeing the work of those 6 teams, it is out on the QSEN website under the Jacksonville University site. The PowerPoints are out there.
Thank you.
My name is Deb Merriam from Damon College in Buffalo, and I very much appreciate the intent of this report and what it represents. It's not reality in my world. 2 of the universities in my area are mentioned and were involved in that. There's 8 other colleges and universities granting bachelor's to doctoral degrees. We struggle with not enough faculty, overloads. I can be excused from being on campus for 2 days to practice. However, this does mean on weekends, I now have to make up because I'm teaching overload and adding in thesis students. I have almost a double load most semesters. So how do we, in that reality, and now having colleges facing cuts, they can't afford to give me release time. I do partnerships with leadership, with area institutions. We're running a collaborative nursing leadership program. It's all on my own time. So how do we move the bulk of these other nursing schools towards this? I honestly don't know, and I would love to hear.
So, I will give you my perspective, and Kathy may have a perspective as well from the broader AACN membership, or others in the audience may as well. So, I think you've put your finger on what is a contemporary challenge in every profession, actually. And certainly it's a challenge for the nursing profession. The issue of how to address bandwidth and what have been very thinly resourced institutions is a really big challenge. I don't really feel I've got an easy answer except to say that this is a leadership challenge that I expect our deans to focus on, to make sure that they're able to develop the faculty resource and to have sufficient faculty to undertake their core training mission while also developing as broader institutional resources. Now that means they need to be fierce advocates, and they need to create new value, and the need to begin to recruit a next level of faculty. It's very under-resourced. It's not universally the case. There certainly there's a cohort of schools that are more resourced than others. I appreciate that, but there are many schools that are very thinly resourced. So I don't feel it's an easy answer. I don't want to just say it's a leadership challenge, but I do recognize it as a leadership challenge. And partly it's to gain the support of the affiliates in that health ecosystem to recognize the potential that lies within our nursing colleges to add real value and to support them so that they could become a little less on the edge. Because I've looked at the finances of a number of these nursing schools, and it is really thin. I appreciate what you're saying. There's very little leverage there. There's very little bandwidth to do new things, and that's a constraint. And I feel it's holding the profession back. So I don't feel I've got a good answer. I do feel that part of the work of this report has been to engage university presidents, health system leaders in thinking about this issue. I do feel that the number of the ones that really are enlightened and committed remains a minority, and that's something to really focus on a continuous basis. Kathy, do you want to add from your perspective of the AACN more broadly?
Well, I would just echo everything Tom said about leadership. We have many types of school in our organization. We have academic health centers. We have 810 members, and so there's only 100 schools that represent that. And the majority are small schools, public universities without an academic health centers, private universities without an academic health center. So you are not alone, and we're very much aware of your plight. But I would say, just as Tom has said, what we need to do is get our chief nursing officers and our deans of schools of nursing working like a hand in a glove to provide you with the resources. Leadership responsibility is to give you the resources so that you can do your job. And if we want to go, and a leader needs to set, here's where we're going, and that's what we're trying to do. We're not saying everybody's going to get there or get there in the same way. One of the concrete things that AACN is doing is we are now establishing an AACN AONE task force. Say that again? An AACN AONE task force that is specifically looking at these issues. And so hopefully we'll have more to say in the future, but we really understand your plight. We're aware of it. We're even going to try to make a report version 2.0 that addresses your very issues.
I appreciate that. And looking at the sustainability, I have a colleague who is in a similar position who found out it really was 2 full-time positions, not 2 half-time positions. She did it for 6 years and stepped back into academia fully because she was just utterly exhausted. So finding a model that's sustainable, I think is important. Thank you.
Thank you. That's a good challenge for 2.0 and the AONE AACN task force. Last question, perhaps? Two more questions.
Just kind
okay.
of a comment from a historical. This is the first I've heard. I mean, I'm like brand new to this, so I'm really encouraged to hear this. I agree with my colleague over here, and I'm coming from this from a historical perspective. I'm an original product of a diploma program that was completely partnered with hospital systems. And so I can't help but think as you're talking that we're getting a new version, not a 2.0, but probably a 10.0 of some kind of a connection between going back to when the health systems now see this incredible need and how we can partner on a broader level, but looking at how did some of those way back when, and the diploma programs, if you're not familiar, came about because there was a tremendous shortage of nurses. So hospitals, which was the healthcare delivery system at the time, sponsored their own schools of nursing. And somehow I'm sitting here going, this is like a reinvention of history in a way. So if we can kind of learn from some of that, it's just a comment I kind of put out there.
No, I agree with you. I've studied the history of nursing and how nursing colleges came to be. They did originate. They separated from hospitals for many reasons, primarily to enhance professionalism, which is a goal that's been accomplished. But I agree with your view. I do feel that there's a tremendous merit in a higher degree of collaboration, leadership collaboration, participatory governance, program integration, et cetera. I mean, I think for a lot of reasons, the colleges of nursing remain and will remain independent from hospitals, in part because of accreditation and other reasons that are very important. But really kind of, really looking more carefully at a more highly integrated model. And I think this is true, by the way, in universities amongst professional schools. Professional schools have become siloed and without a sufficient degree of communication and joint programmatic and curricular development, which is called for but rarely realized. So I would say your comment would also extend to professional schools.
Oh, I couldn't agree with you more. I'm in an interprofessional program right now, and I'm just like totally in agreement with you. We have all the right ideas, but in practice, it's not exactly happening. But it's open. It's always good. I try to be an optimist to say it's good to have something to look towards as well. So
I agree, and we can work at this at different levels. I think it's helpful. We have a lot of frameworks that are out there. There's the IOM framework, there's QSEN, there's IPEC, there's New Era, there's these different components out there. The real work gets done at the programmatic level in the context that Terry described, and we need more of those efforts and initiatives, and more curricular innovation, and more new care model development, and so I think stimulating and being tireless, because I think the comment that was made by your colleague earlier, people get burned out. They're not, and this is a huge marathon. So kind of where can one draw the sort of, spiritual nourishment to continue on? And of course, it's a very wonderful thing to do to change how a healthcare system operates for the better. But I can appreciate that the crush of daily responsibilities can extinguish that in so many. So I appreciate that challenge, and I think that this is very important for part of the reason why I think it's very important to have a pipeline and to develop the next generation of faculty and nursing leadership broadly, to really invigorate and have that next generation really see the future and work with them, turn over the reins, give them leadership. I feel very strongly about that. Mentorship and leadership of the next generation is very critical, and the generation after that.
Ann Stalter, Wright State University, Dayton, Ohio. So, we are the gem city where innovation took flight. So if I could figure out how to use the fatigue that's been talked about to create anew, I would come to you and give you the answers. But the fatigue is a real issue. So thank you for recognizing that. In 2.0, I ask that you address the strategies for the affiliates, those with affiliate contracts. It's very interesting to know that we have somebody who's going to be a CNO and a dean. I think that is awesome, because that, don't you think that's really cool? I do, and I think she may be able to set a new agenda or a new vision for many of us to follow as a national model, because that first recommendation, that's the important one. If we could all get that one accomplished, that'd be great. But, we know, academics know our place, and the practice providers are really our customers. And it's very difficult to be on the same platform and to deliver to them in a dynamic environment where there's no money. You know, that's tough. So it's hard to go, okay, well, we've got little pieces of programs that we can do, but without that upper leadership and the resources, we can't accomplish it. Mm-hmm. So 2.0, we need help. Please. Okay, thank you.
Thank you.
Hi, I'm Corinne Abraham from Emory University. I am one of those with two hats. I have a joint appointment with the Atlanta VA and at Emory School of Nursing. And I think part of what I just want to address is, and it relates to one of the pillars, is about aligning what we do among both of my jobs so that it's meeting both. I'm not feeling like I'm doing two different jobs, though some days it does. And an example of that might be as the director of the DNP program, I'm on committees, let's say with the healthcare system, not just the VA, identifying needs in the organization where we can add value to them, where there's a win-win. There's a win for our students, there's a win for our academic center, and that we recognize the value of having trainees in the health system, and that bridge that facilitates really maximizing trainees in the health system is the faculty. So in my joint role, I'm able to bring interprofessional trainees in. I coach quality improvement that aligns with my job at the VA, but also aligns with the strategic plan and priorities of the organization. So it's seen as a win-win for the academic affiliate as well as the organization, and it's training the next generation of trainees. And that's kind of how I envision what I do, and I think that helps with some of those pillars.
You don't seem too fatigued at the moment. No, I think it's, I think drawing strength from the integration of education, practice, and research is so vital. And not viewing these as burdens, but as opportunities. But not every institution, Emory is an unusual place. So, and it does have resources. So, that's a factor, I'm sure.
Hi, it's me again. I'm from San Francisco, University of San Francisco, the Jesuits, not UCSF. Dare I ask, you've mentioned the word authentic many times.
The word?
Authentic.
Yeah.
Which is great. Nurses are the most trusted profession. Do you see any hope for partnerships with for-profit companies in the future that may have the financial resources to work with us within guidelines that are not in conflict? There's a lot of startup companies that would like to maybe capitalize on partnerships with nursing. Do you see that in any way happening in terms of supporting the financial leadership that can take these new partnerships to the next level?
So I think there's always opportunity. I don't feel concerned about conflicts. I think it's, for-profit companies are, so to give you an example, so I think the answer is yes, but as an example, so I've done quite a bit of work with Duke. Duke has a partnership with LifePoint, which is a for-profit company, and they've developed something called the Duke LifePoint joint venture, in which LifePoint buys community hospitals and Duke provides a quality and safety template which they implement to raise the quality and safety of that institution. It's been very successful. It really works well. And that's just one example. Teladoc is a major telehealth service provider that has maybe last year did 1 million telehealth visits. It's the premier for-profit telehealth provider. As far as I know, they employ quite a few nurses, as well as physicians. And so they have a service that they're delivering. If a for-profit company like LifePoint or Teladoc is delivering a service, that creates the opportunity, perhaps not for a partnership, but perhaps for a contract, for a relationship. So I think it would be invigorating to work with a for-profit because they're very focused on service delivery, but they're an important part of our healthcare ecosystem. So I think if there's an opportunity, and of course where you are in the Bay Area, there is a lot of action. There is a lot of startup development. It could create an opportunity. but it would likely be more contractual in nature rather than a quote partnership, would be my expectation. So, but one should think broadly about how to finance our schools of nursing in the future, because it's a real challenge. Resourcing is a big issue, and one needs to look creatively and innovatively at every option, including the one you described. So I want to thank you. I thought this last part of the session this morning was really helpful for me. I just really value hearing from you and your contributions to help Kathy and I think about what we're trying to accomplish here with the new era. So just really appreciate that very much, and thank you.
One more plug. As you know, AECN is very, very passionate about this work. We're doing everything to advance it. So I want to let you know that we have a new era nursing award that the applications are due by June 30th, and the award is going to be presented at our fall meeting. And so I've heard so many good stories here this morning. If any of you are doing any great work, and I know you are listening to me this morning, to implement any of these recommendations, I strongly recommend you for the award. So thank you, and again, thank you, Tom, for a wonderful presentation. Have a great day.